Okay, good morning, everybody. And thank you so much, Argentina, for agreeing to present today on a short notice. You saved the day, so we're very grateful. I'm going to give a very brief introduction, and then I'm going to let Argentina take it away. Sorry, I'm dealing with multiple windows here. So Dr. Argentina Servin is an assistant professor in the Division of Infectious Diseases and Global Public Health in the Department of Medicine, as well as in the Herbert Wertheim School of Public Health and Human Longevity Science at UC San Diego. She's a bilingual and bicultural clinician researcher with training in preventing medicine, infectious disease, and clinical epidemiology. Her work has included assessing sexual and reproductive health education, gender-based violence, and intersections with HIV, STI risk and prevention, and health service utilization among vulnerable and underserved populations, including female sex workers, adolescents, and at-risk youth, migrants, and refugees in both domestic and international settings. Based on this research and her years of clinical experience serving vulnerable populations, she has developed a strong interest in improving the health of medically underserved communities by developing, implementing, and evaluating clinic and community-based behavioral interventions centered on linkage into care and reducing barriers to care in under-resourced settings. Since the outbreak of SARS-CoV-2 in 2019, Dr. Servin has been actively engaged in efforts to address health disparities related to COVID-19 among racial and ethnic minorities in Southern California. And today, again, she will be presenting on the use of CBPR for addressing COVID-19 vaccine hesitancy among Latinx and Black communities in Southern California based on her recent research. Thanks again, Argentina, very much looking forward to hearing about this research.
Awesome, thank you so much for having me. It's a pleasure to be here. So really quickly, I have no financial, no relationships to disclose, but this work is funded by the NIMHD. So as you all already know, when the pandemic happened, or a couple of months into it, we realized that minority populations in the US were severely affected. And we know that there is no genetic predisposition among people of color for COVID-19. It just had to do with, pre-existing conditions, the fact that we tend to live in more high density neighborhoods, that we were frontline workers, that, we have pre-existing conditions such as diabetes and obesity that placed us at higher risk, also lack of insurance and good quality care. We have here data from 2020 that there was, we also saw that there was more hesitancy among minority populations in the US, and that also has to do with a lot of, historical racism and bias in medical care, unfortunately. Now, more recently, we still see that the hospitalization and death rate is higher among Latinx and African-American individuals compared to white counterparts. So along came Project Tu Vida. So this is the fastest grant I've ever written. There was a notice of special interest from NIMHD centered on addressing vaccine hesitancy among high risk populations or underserved communities. And I remember it clearly came out December 17th, 2020. And it was submitted on February 12th, 2021. It really does take a village. It is still a large community effort. It builds on the principles of CBPR. So I feel very blessed and fortunate to know all these amazing individuals and be able to work with them. So it's a partnership with different community-based organizations. And our largest partner is San Ysidro Health, which has been amazing. They're a local federally qualified health center, as you all know. And then, we're working with community leaders as well in the Latino and African-American communities. So it does really take a village. These are all the different organizations that we're currently working with. And I say currently, we are transitioning now into a more endemic phase, but we still want to continue to have some community presence and to promote relevant information about about COVID-19, because as you all know, when something becomes endemic, the most vulnerable populations are the ones that are affected. Maybe it's not affecting everyone, but it's still affecting, our community members. And so I'll get more into that at the end of it, but it really does take a village. Extremely grateful for everyone that's been a part of this work. And so these are our study objectives. Oh, I forgot to mention all the images that you see. We do have permission to use them, and it is really actually us on the ground. And so we are evaluating TB compared to the standard of care for COVID-19 vaccination services, and we're trying to assess feasibility, acceptability, and intervention effects. This is where we're the study setting where we're working on. So we're working across San Diego County, but we're specifically working in communities that are predominantly Latino and African Americans. So we're working in San Isidro, Chula Vista, National City, Valencia Park, Logan Heights, and Lincoln Park. This map is actually from COVID, number of COVID cases from the beginning of the pandemic. So they were also the areas that had the largest number of cases and infections. Our study design, we're focused on COVID-19 awareness and education, outreach, community outreach and health promotion, as well as individual health education and linkages to supportive medical and supportive services. And then we provide the vaccine through our mobile community pop-up clinics. This is a little bit of what we have as far as COVID-19 awareness and education materials. So we have a website where we try to have an updated calendar of our community events. We have information and resources, services and resources. So sometimes folks can log in and they can even get information on if I don't have a provider, or, you know, how do I know if I qualified for a government sponsored insurance, et cetera. And then this is our Instagram, which has evolved a lot from, I think we've gotten better at how we communicate information, but I think, you know, a lot of folks here in the room are clinicians, and usually the information that we provide in the medical field to our patients sometimes is not the most digestible one, or it's not the most visually aesthetic. So we really worked on that really hard. And we also have community members' input. So we actually have leaders of the community look through our information, the resources we develop. We also work very closely with a group of promotoras who are constantly out in these communities and have a relationship with the community members, and they give us a lot of feedback. So obviously you can see, this is just some examples that we took. We have handouts as well as our social media, different social media platforms, but obviously you can see how these things have evolved, right? When we had the Delta variant, or when it was a breakthrough case. Currently, we've distributed about 60,000 educational materials, both in English and Spanish. On average, our social media posts, specifically our reels, get about 10,000 views. You know, we have a group of undergraduate research assistants that work managing social media. Young kids have great ideas. They do polls and they actually get responses from people that like, oh, I didn't know that I need to get my booster, or we get direct requests actually from community members for a pop-up or for any resources that we could provide. So it's been great to have like a direct connection. And obviously we're targeting Latinx and Black communities through posts and advertising. And we've developed an average about 60 different educational materials and resources. So what does our community outreach look like? We didn't reinvent the wheel. We went back to the basics. We literally canvassed door to door. Every time we had a pop-up clinic, the group of our RAs, they're amazing. Myself, you know, our promotoras, we literally went knocking door to door, handouts like, hey, we're going to be here on Tuesday. Come join us. We're going to have different resources. We're having a mobile clinic. We tried to have a medical team as much as possible on staff for these clinics in case people wanted to do a provider visit and they don't have a provider. If they need additional care or resources, we would link them to the closest San Isidro Health Center and see if they didn't have insurance, if they could qualify for a government sponsor insurance. So we also hosted community engagement forums. This was like around April 2021. So we still couldn't do anything in person, but we had really good turnouts on these Zoom sessions. Like I remember for 2-3 months at a time. We had every Friday, like 4 or 5 sessions, and we had about 70 to 80 people turn out from different faith-based organizations or other channels through San Isidro Health, where folks would show up and they would ask genuine questions like, if I'm pregnant, can I get the vaccine? Or, you know, how do I get my granddaughter wants to travel and we live together and like I'm high risk, how can I manage the situation? So genuine concerns from our community members, and it was really nice having that one-on-one interaction with them in these forums. And they were done both in Spanish and English. And then this is the beauty of partnering with San Isidro Health is that we are able to provide other services. So we've done blood pressure screenings, glucose screenings, COVID-19 tests at a time where we had surges that there were no tests available, and people were waiting long times. We also partnered with Co-Create at that time to be able to provide enough testing. We also do HIV and STI. As I already mentioned, we do provider visits. We also work with behavioral health. Local food banks is something that we've done a lot, and obviously transportation vouchers when those were available. So the goal of these pop-up clinics is to provide vaccines to these hard-to-reach populations. So a lot of our pop-ups happen at grocery stores, at the local community park. And so it's literally catching people as they're, you know, running in. Maybe it's a mom with 3 kids, has no time to go because she doesn't have, you know, childcare. Or a lot of folks that work in construction is something that we also saw. A lot of servers, like people that don't have a regular, you know, job where they can actually take a break and like go and get the vaccine or go visit the doctor. Obviously, things have evolved, as I mentioned. So when the project first started, we were doing community pop-up clinics 4 to 5 times a week, excuse me. Currently, we only are doing them about twice. We do every Friday, excuse me. And then moving forward, once we finalize our data collection efforts, we are planning on doing once a month selective community outreach events just centered on education and kind of like next steps or like what happens, you know, after COVID. But since July 7th, which was our first official pop-up, we've done 98 pop-up clinics. We've distributed 1,978 COVID-19 vaccines. We've enrolled 989 participants, and we've linked individuals to 4,000 plus services. We're not doing PPE kits anymore because we've evolved from wearing a mask and using oximeters, but we did distribute a little bit over the 2,000 PPE kits. So some preliminary findings, these are just basic descriptives. Our population, as you can see, they're about 47 years old. We have more than half has less than high school education. Is there a question on the chat? If you can, I can't look.
No, it's just the people registering for their credits.
Oh, sorry, thanks. So we have 45% live below the federal poverty line, and we have a larger female than male population. As far as race ethnicity, so the demographics of our sample mirror the demographics of San Diego County. So 87% identifies as Hispanic, Latino, or Latinx, and 6.4% identifies as African American or Black. And close to half of the population were employed, and 45% reported a government-sponsored insurance, but 27% reported no insurance. And then we also found 34% reported not having enough money to pay for rent, or 7.5% reported not having enough money to pay food, or other financial challenges. IPV was very low. We think it was severely underreported. Only 3% reported IPV, and 66% reporting having pre-existing conditions. As far as trust, so we're actually working, there's a medical student who's working as ISP focused on this. He actually found that, it's a manuscript in preparation. He actually found that individuals who had mistrust in like different news outlets, as well as those that thought that COVID-19 had been media hyped, were actually more likely to have vaccine hesitancy. And likewise, those that don't trust the healthcare system, specifically those that don't trust the healthcare system and the CDC, we're also more likely to be hesitant for the vaccine, which kind of makes sense. Now, as far as future directions, so I gave this talk, I think I was here a couple of months ago. We still need to tackle parental vaccine hesitancy and rural health disparities. So there's almost 15 million children under the age of 4 that have not been vaccinated for COVID-19. We also need to work on achieving vaccine equity globally. I mean, the CDC is moving forward with the second booster, but then when we look at data globally, and we're really globalized. People are traveling, back and forth everywhere. Unfortunately, the data doesn't look the same in other countries. We're also Diego, Miss Cynthia James Price. I love her. She's amazing. And we submitted a grant together. So we're really excited and fingers crossed it gets funded. But it builds on the concept of going out to the community, doing these mobile clinics and providing services and linkage into care. And then something that I'm really excited about, aside from working on papers for peer-reviewed journals, we're actually starting to share the preliminary findings with our community members and partners and linking it to local resources. So for example, the data that I shared that about 7% reported food insecurity. So we're actually working on a handout and on a post through our social media, as well as a newsletter that we'll distribute with our different the different CBOs and NGOs that we've been working with for almost 3 years. So basically it's like, okay, here's the, TV does a study that was focused on this. Here's our preliminary findings. Our community reported, close to 8% having food insecurity. Did you know that there's some local resources that you can utilize? Like, have you heard of SNAP Ed? Maybe you can qualify for it. Here's the dates of the local food banks, in these communities. Like, this is the day that they do food distribution, for example. We also partnered with a local nonprofit that works on housing and housing insecurity. So we're also working on another kind of handout / newsletter that we're going to hand out the remainder of the community pop-up clinics that we have for the month of April and May. But basically it's like, hey, 30% said they, didn't have enough money to pay for rent, or they had housing insecurity. Did you know that these are the local resources available? Like, here's how you apply, ask us, etc. So we're working uncombing the data to make it really digestible, understandable, and kind of like to the point, but also normalizing and destigmatizing a lot of these issues that people don't feel comfortable talking about. While I don't work in the area of food insecurity, I do have friends and colleagues that work in that area. And a common thread is that a lot of people qualify for these government-sponsored programs like SNAP Ed, but they're embarrassed, they're highly stigmatized. So I think that opening up the conversation and normalizing it, like, hey, this is what our community reported. Here are these resources. Do you qualify? Are you interested in learning more? So that's something that we're just started working on. So we're excited. Same as with the information about mistrust in the vaccine and the health department and the CDC. We still don't know what that's going to look like, but we're excited of starting to share the preliminary findings to the community. Not only say, we have we work with, we have our, so obviously before we're working on developing them, and before they go out to the large community abroad, we are going to have our CAP review this information. But aside from saying, hey, does this relate to you? It's more of normalizing, and here's a solution or a potential solution, kind of linking it to those services. So I'm excited for that phase. Now, as we transition more into an endemic phase, we will no longer be offering community pop-up clinics, but we do want to have once a month community outreach events where we provide relevant information that we think our community, based on their input from the community members and the promotoras. For example, in October, there's it's Cancer Awareness Month, and there's a large women's health fair that's done here in Chula Vista. So we want to have a booth there, and we want to figure out what resources we can provide related to COVID-19 and the grant, but also related to the community needs, and, you know, kind of changing that message, right? The message is no longer, for most of, you know, our community, it's not about, you know, staying isolated and wearing a mask and gloves. Everybody's out there again. But it's more of like, what happens if I'm immunocompromised? How do I protect myself? Or, you know, if I have long-term COVID, are there any resources available? Can I participate in a study? Like, information that we think is more relatable, or, as I mentioned, linking to these services based on the needs expressed by our community members. So that's all for me. Thank you very much for your time. Oh my God. Obviously I wouldn't be able to carry out this work if it wasn't for the amazing team that we have, for all our community members, our study participants, and our funders, the NAMHD. So I don't know if you guys have any questions.
Thank you so much, Argentina. That was so interesting to hear about all of these experiences. Your Christmas holiday in 2020 must have been amazing, frantically writing a grant in the midst of a second wave.
With a 6-month-old baby crying on my lap. Yes, it was amazing. Oh, I see.
Comments in here. So Danielle Wallace posted resource to find vaccination rates by race and ethnicity and age group on the county website. Thanks so much for sharing that. And Dan was saying that sharing data with the community after a study is such an important thing to do, but is often forgotten. So glad to see the continued commitments with these communities. It's open for questions. I'm going to ask the first one just to get us going. I have about 7 questions, but I'm going to start with one. In terms of, will you be able to to identify those who went from not wanting to vaccinate to actually taking the vaccine, and pinpointing to what made them change their mind about it?
Yes, so we do a baseline, and we do have follow-up survey, and we did have some open-ended questions. So it's a matter of combing through the data. We do have information on what made them change their mind. I haven't looked at it yet, but we do have that information. What I do think that, oh, Alan, we have a question right now. But I think it'll be interesting. We did center more, though, full disclosure, on the children, like, because we were working on another grant focused on parental vaccine hesitancy. So we also have a lot of questions like, would you vaccinate your child if you have a child under 12? Like, yes and no. So we have more of that information than overall. But we should be able to identify some of the reasons, but we did leave it as an open-ended question. For the most part, people did report just trust in the vaccine overall, like in the side effects. It was reported about 55% of the people were concerned about the side effects. That I do remember, because it's like so strong. And then I saw a question here from Alan in the chat, if you don't mind. So we haven't reported the results to the community yet. We just started conducting these different analyses. So because it's a group, folks are working on different pieces of it. And we haven't reported overall to the community yet. We've talked to the CAB and our community leaders that we work with. And they're not super shocked with the data, like as far as food insecurity or like economic issues or like pre-existing conditions, like, as you all know, like, for example, hypertension is a great problem on the Black community. So they're not completely shocked. They're actually excited of the fact that we're going to kind of give the information back with resources linked, like local resources, not saying you can go to this website, actually saying, hey, there's a food distribution, for example, a food bank on your community every Friday at this church from 8 to 2 or something. Like, we're actually kind of trying to go that extra mile, not just posting a link or a website, because I know my mom will never go on a website. So she's older, so she needs everything more digested. So we might have issues But at this point, we haven't yet, but because we have multiple people screen this information, so San Ysidro Health will look at it first, and then it's like layers, and then, the CAB looks at it, and then after that, our different community leaders that we've been working with, like Miss Cynthia, will take another stab at it. And so it goes through different filters before it actually gets out there. That's what we did with all the educational materials that we've developed for the past couple of years. And it's the same process that we plan on doing as we return the information to the community. So more to come. I'll let you know if there's any issues, but it does go through multiple layers.
There's no other questions. Oh, there is one. Dan. Oh, go for it, Nettie, probably.
Oh.
No, go ahead.
No.
Since I interrupted, sorry, Dan. I was just wanted to take the opportunity to thank Argentina for the wonderful presentation and mention our delight in participating in this project at San Ysidro Health. But also, every time I hear these kinds of summaries, it just gets me wanting to sort of get on that soapbox about how important it is to do research that actually helps people right out of the gate, as opposed to research that is waiting to find out an answer later that will maybe help the community with some kind of answer to a question 10 years from now. Not that that's not important, but when you're in a community health center, we really like these kinds of projects where the research itself is directly benefiting the population on day one. So this is very exciting, and this is the kind of project that we get excited about. And I feel like we're seeing more and more of that, where the research proposals really both have a long-term question and a direct short-term impact. So I wanted to congratulate you on that.
Oh, thank you. It wouldn't be possible without your support. I still remember that first meeting where we're all masked up in San Ysidro's large room, and we're on that drawing board, and you were like drawing and this and that. I'm trying to take notes and catch up with all these different ideas. So I'm extremely grateful and thankful for all the support that you guys provided. And obviously we have more grants together, so fingers crossed something will get funded.
Thanks, Argentina.
Yeah. Daniel, oh, that's a great idea.
Yeah,
And
I just thought that, sometimes, since you're looking at trying to, also help out the community in terms of food services, maybe, trying to pair up, or, different communities. You've probably already, are aware, certainly with like the Black community, there have been efforts in terms of, in barber shops and reduce, pairing with hypertension interventions, those kinds of things. But especially now that, there's now the new guidelines saying about, repeating vaccinations. I think there can be still a lot of work from that standpoint. Of course, we have people who have been vaccinated, but then trying to get them sometimes a second vaccination or continued vaccinations, I think is still a challenge. So finding out what the community needs and maybe somehow pairing an event with that.
Yeah, I definitely agree. So we are seeing booster hesitancy. And there's a lot of misinformation or misconceptions where people think it's only for like my grandparents. So there's definitely hesitancy with the booster. And I love that idea. Something that's unique about our project is that these pop-up clinics that I mentioned, we come back every 3 weeks to the same site, so people know that we're there. That's has been the hardest part, though, as we start wrapping up data collection and as we evolve into this endemic phase, people are kind of sad and disappointed they're not going to see us anymore, because some of them might not have a primary care provider, and so that's where they go get their blood check. And I will say we did use blood pressure screenings as kind of what's the way to say it?
Syndromic.
Well, we used it as a way to lure people in to get the vaccine. So like, hey, we're doing re-screenings, come. And then, hey, have you had the vaccine? And so, but we, I'm sorry, but it's true. That's so awful. But that's the way that we used it to get people to come in. But moving forward, I think that's the hardest part. So that's why we're committing for the rest of the, from June to December, when our next funding cycle, we're committing to these once a month outreach events that are happening in these communities where we've been so long, to not leave the community just hanging and be like, well, we got our data, have a good day. But to Daniel's point, the fact that we go to the same community site every 3 to 4 weeks gives us an opportunity to link it into these different services, as you mentioned. The food insecurity is one that I feel it's easier to tackle because we know the resources available. But we also have, as I mentioned, an NGO partner that they do housing, their transition housing. And so we're trying to figure out how, now we have this preliminary information, how can we do another pop-up clinic with them in order to have those services available as well?
We have a comment from Scott here saying behavior tends to regress towards, oh, sorry, there was one by Nettie first, I think. It was Scott first. Behavior tends to regress towards the baseline usual behavior when the acute threat is gone. And I guess that's what you're seeing, right, Argentina?
Yeah.
And do you want to elaborate on the booster?
Oh, sure. I was just picking up on Dan's comment about, pairing interventions to try to get boosters. And I think enticements, or however Argentina was trying to find a word for it, pairing it with the food, things like that, I think are a great idea. And we just kind of launched into a sideline about vaccine booster hesitancy. And I think the word is going to be slightly different. Like when we look at the factors associated with boosters versus primary series, a lot of what I'm hearing from people, I have people who were gung-ho on vaccines, but they're just tired of them. And so I think it's going to be, the next wave is going to be a slightly different language and different sets of interventions to try to explain to people the public health benefit of, say, like an annual COVID vaccine. And that's not necessarily the same as some of the vaccine hesitancy or misinformation. It's kind of more like, now we have the misinformation, but we also have sort of a fatigue factor we'll have to deal with.
Yeah. I couldn't agree more, unfortunately. But yeah.
And I want to on Nettie's comment about the importance of research that helps right out of the gate. Clearly the process was incredibly fast, and I know the NIH made an effort to have these like rapid funding streams, but still, do you feel that was fast enough, or that something could have been done to start earlier?
Of course not. No, I mean, I think everybody in this room can answer that question. It's not only for me. The whole process takes a while, right? Like we had to, the IRB, like we couldn't get started. I mean, there's a lot of, issues. There's a reason why you have these policies in place, obviously. But of course it wasn't fast enough. I think that we should have prepared the community at large as the vaccine was being developed in a more digestible way. Like people just were like, what is mRNA? What is this type of technology? It's like, no, it's actually been, in the lab for 20 years. So it's not that new. Or, we had a previous outbreak and we used these trials. Like there wasn't enough information readily available, and that allowed for a lot of misinformation. So it definitely was not fast enough in the funding, but also being more transparent on what these processes look like in general in research and science, I think is important. At least that's what I'm learning from the community. People want to know, people want to advocate more for their health. And I think it's just a matter of providing the proper resources in the channels when we communicate. Now, there was also a lot of back and forth with the recommendations and guidelines from the CDC. And so I think that I get asked this, I still go to the community pop-ups and I get asked questions a lot. And I always remind people, there's a reason why it's called the novel coronavirus. Like there was a lot of unknowns. And I think that's something that we tend to forget in our messaging. And I think it's okay to say that, there's a lot, we're learning more as it evolves. And this is what we learn, and through your participation, we're learning about X, Y, Z. I think that's also really important, but definitely the messaging and how we communicate. Sorry, I went off topic, but no. And sorry, yes, I think it should have been faster. We submitted in December and it was awarded at the end of April. It was a fast track, but I think it should be fast for everything. Oh, yes, we did, Alan. Actually, we got yelled once or a couple of times at the beginning at a pop-up. I was like, please don't shoot us. Some gentleman in like a large truck ran by our pop-up, and like we had the mobile unit. I was like, what did he say? I think he said we're gonna burn in hell or something. And so we definitely got a lot of that, or like, you guys are doing, the devil's work, as we were handing out, outside of these grocery markets and these parking lots, handing out information about the vaccine. So there was definitely a lot of opposition about the vaccine in the community. A lot of incidents like that have happened. A little bit more so less now. But we did face that at the beginning. Sorry, I forgot this was being recorded, but yes, we did get yelled a lot of things, unfortunately.
We will edit accordingly. There's also a question from Anna that says, do you agree with the idea that there should have been fewer guidelines or overall less involvement from the CDC in an effort to decouple vaccination from mistrust?
Yeah, that's a hard question. I mean, out of all the organizations that we asked for, CDC is the organization that there's definitely a mistrust reported, and it was actually significant as far as getting the vaccine. So I do think not only perhaps not fewer guidelines, but just more clear communication. When they came out, do you guys, you might recall when they came out with the difference between when you have to isolate versus when you have to quarantine. It was so confusing for people to understand. And 2 days later, I think they came up with a different message. And so it just seems on the outside from the community, it seemed like they didn't know what they were doing. And maybe they did, but that's the perception and that's the response that we got from the community, that like, who do I listen to? I don't understand. And so perhaps they should have done more consensus before coming out with guidelines, and maybe explaining more of the thought process behind these guidelines and recommendations in a way that's more digestible for the community. But I open that. I would welcome anybody else's thoughts on that.
No thoughts on the CDC. Going back to this idea of fast response, I mean, I'm wondering whether all of these studies, including yours that were funded during the pandemic, does this mean that we will be much better prepared for the next public health crisis? And could, for example, your intervention just be applied to like the next pandemic? Or
well, we're building on this concept for non-communicable diseases. So the grant that we submitted to Compass is actually focused working with the Black community in San Diego and hypertension. And so I think that overall CBPR projects can be applicable to both preventable or infectious diseases and chronic diseases. I think that, going back to the other question about the CDC and what you just asked right now, I feel like we reacted really fast to monkeypox and then as a public health emergency, and then it wind down. But then with COVID-19, we didn't act fast enough. So, I think that happens. But I think that CBPR can be used for any public health, not only public health crisis, but just in general. I think it's something that we forgot about. And I think that it has a lot of benefits, as Nanette alluded to earlier, right off the gate, having the community involved from the get-go and getting their input versus the other way around.
Yeah, I'm kind of thinking, well, if in 5 years there's another pandemic, could you simply, send your current intervention to the NIH and say, we're ready to go, just fund us, and it will take.
Oh, that would be great, but I don't want to live through another public health emergency. I'm okay with it happening in another 100 years. But yes, I agree. I mean, at some point we talked about the NIH was interested in HIV vaccine. And they had a special call. And at some point we considered it partnering with the, local needle syringe exchange programs and whatnot. But then the funding announcement went away. And I mean, everybody in this room works in HIV and we've been waiting for a vaccine for years. So, but I do think it's applicable to other areas.
And I was interested as well in hearing a little bit more about the CBPR approach now that you're kind of mentioning the importance of this. I mean, I understand you had the community advisory board and you had your community leaders. What would you describe as the main pillars of the CBPR approach?
Well, they're part of our research team. So like they sit in our meetings, they looked at the grants, they gave feedback, they gave us ideas on like, no, this isn't going to work. This is the best way to do these things. I mean, nobody, especially these community leaders that are advocates for the health of their community, nobody knows, the ins and outs better than they do, right? And what their needs are. So it is a lot of, I'm not going to lie, it's a lot of work. It's a lot of going back and forth. But I think it's important to respect each other and to be mindful. So we actually even present findings together. We went to APHA and they were all like the whole team, like, or half of the team was there. Like we actually flew out our community members to be there, to be in the session, to give their input and kind of help share some of those preliminary findings. So I think that when you find community members that are such strong advocates for their health, I think that you should stick to them. When you find these good community partners, you stick to them and you nourish and you build that relationship as you would do with any other relationship that you have, because these turn into long-term commitments. So I will say something that I forgot to mention in the beginning, because I was basically born and raised here in San Diego or in the /Tijuana region. These partnerships didn't just happen. Some of the folks that I've had the honor and the privilege of working with were my teachers when I was in medical school, were my mentors when I was a postdoc. We were both postdocs and now, they have a high level position at the county. So these are relationships that have been fostered for the past 10 to 12 years that, knew who I was and knew the work we were doing. And when this crisis happened, we're like, hey, we have this idea, let's work together. And actually some community members
Thank you, Argentina. I think that's a really good point that keeps coming back, right? Like CBPR has become fashionable and sometimes kind of almost required in some grant mechanisms. And it's criticized when researchers just go and try to build a partnership in order to get the grant. And then it's not like a true foundation for a long-term collaboration.
Yeah.
I don't want to take over space for other people to ask any questions they might have. But if there's no other questions, I have another one. I think you mentioned it, but I was curious about, like at the very beginning when there were still social distancing measures going on, how did you handle that to kind of like both be close to the community and deliver messages and abide to these social distancing requirements?
Of course. So we always, and still to date, we are still wearing masks. So everybody in this, we just followed the basic, guidelines recommended by the CDC as far as distancing and the masking and whatnot. I think that just overall kind of introducing yourself when we were out on the pop-ups and being like, I'm actually, a researcher with UC San Diego. We had like a nurse on staff, like, hi, I'm like the nurse for this project, etc. People really like the idea of engaging one-on-one with public health practitioners and just overall with engaging with a medical team that could also talk in their language. I think they appreciated more that part. They understood that we had to keep our distance and the masking and whatnot. And as I mentioned, a lot of the community engagement forums that we had at the beginning in our town halls were virtual. I honestly thought nobody was going to show up. But when I saw that there were 80 people in the room, I was like, wow. And they actually all had questions. And these forums also happen off hours because, like, for example, at Southwestern College, they had like adult school. So I was giving a talk at 7 p.m. And that was okay because they had real questions and we were there to offer real answers. So they really welcomed the idea. They could talk to a provider, to an expert in the field one-on-one without being judged. So even though we had the masks on, they were still happy about that engagement. Because sometimes, unfortunately, maybe they don't have a primary care provider, or maybe they don't have enough time during that consultation, especially at that time with the health system kind of adapting to everything.
Thank you. And I remember that when the pandemic was happening, one of the main risk factors that were mentioned for Latinx communities were the fact that many of the households were multi-generational. Is that something that you experienced? Like, were many of the questions asked, or were many of the stories that you encountered related to this multi-generational aspect of households?
Sorry, yes, we did. We did have a lot of grandma with grandchildren and daughter, and how she was concerned that, or they were concerned that they're trying to isolate and, or limit their interactions and their, masking because they're at risk, versus having the children and grandchildren kind of go out there. So we definitely had a lot of concerns, and we did see a lot of multi-generational households. So a lot of the data that was being reported related to what we were finding.
And if it was another wave that was serious, would you be prepared to just relaunch? Like, would you even have the funding to relaunch? And
well, I was going to say, with permission. So something that's characterized the pandemic is that it's been ever evolving. It's constantly changing. That's the only one constant thing. There's always change. It's always been changing. So initially, we did have to change our protocol, and we did have to request permission from the NIH for a couple of changes. So first one was to offer for the 2 series vaccine and the 1 series at that time when we had J&J. And so we did have to request permission to offer that. And then when there was a booster, we had to request permission. Can we offer the booster? Which they approved. And then when the vaccine was available for individuals under the age of 18, we requested 16. We thought that was a good age, and with consensus from our community members, they agreed 16, not 12. We still offer it if someone comes and they want to, but they're just not part of our study. So that's the other thing that we requested permission for, is like, if they come to our mobile pop-up clinic, can we provide the vaccine even if they don't want to be part of the study? Because we're talking about equity and equality, right? And so that is the case. So we are able to offer the vaccine to anybody who's interested. We don't always have vaccines for children, only if we know that it's going to be an event where there might be children, even if they can't be part of the study. But if there is an interest from the parents, and given the the low levels of vaccination rates among children, we do offer it at times.
Nice.
I don't want to minimize the importance of funding. So please take this in that light, which is that we absolutely, it's very frustrating when you have these mandates and there's no money to do them. But on the other hand, I will also say that just for future thought and future collaborations and projects like this are great for, quote, leveraging, which is like my favorite word for how to make our complicated HIV budgets and clinics kind of fit together. So you may have money for one thing, but not money for another, but your friend has money for this other thing and you don't. So putting projects together like HIV testing, collaborating with the research project, or having multiple things happen simultaneously is a great way to get around that sort of siloing of funding.
I agree. And that's something that Sandy Cedar has been really creative with. So we're thankful for that partnership.
This makes me think as well about what you were saying in terms of like lots of organizations got together during COVID to respond to the crisis in a harmonized way. Do you think that this has stayed that way, and do you think it has created synergies that will last for a longer period of time?
Well, as I mentioned earlier, that's the long-term goal, at least for myself as a researcher, which is why we've been competing for additional funds through the NIH that built on these different relationships that we've established in the community. So fingers crossed, hopefully they want to continue to fund our work and fund us. But that's the goal. And by the way, I'm also more than happy if anybody here is interested in any of the communities that we've been working with to help us establish a contact or a relationship, if that's something that anybody here is interested in working in. I mean, I am very, very grateful for everyone that's been a part of this, and I'm always happy to connect folks as well.
Thank you, Argentina. Well, I know you have a meeting at 9 and that you have to get going, but thanks so much for this interesting talk and sharing all the experiences along the way. It's definitely a very specific type of situation, and you navigated it very well. So
thank you. Thank you so much for having me. And I always say, I hope we get back to a better normal where there's not so many disparities, at least in healthcare. But thank you so much for having me. It's always a pleasure to see everyone, lots of familiar faces. Thank you so much. We'll be in touch. Bye.
Thanks, everybody.
Have a great weekend.